Hey gang, it is Wednesday. You know what that means? That means it is hump day. It is happy hour. It's hump day, which means it's time for Dentists in the Know. So I am Dr. Jeff Horowitz. That is Dr. Jennifer Bell. And Dr. Chad Duplantis is unavoidably detained tonight. We will miss him dearly. Yeah, we don't know what's happening. There's just a lot of stuff going on there. So, Chad, we love you. We will miss you tonight, but for the rest of us, we're gonna have some fun. So we are all practicing dentists. We're all educators. We're all business owners. Our job is to bring all of you in the know. We have an incredible show. So what I really love about how we started is the fact that we have another one of your mentors on tonight,
know.
JB. So
just parading them around for everybody to be jealous about.
Yeah, so right. But I love this because it's really cool to see how people can impact somebody else's career and then have it come back full circle, just like this. So we actually have the chair of endodontics from the University of Missouri, and she used to be at UNC, where JB went to dental school. And her name is Dr. Weisleder, and she's an amazing person. I just got to spend a little bit of time with her. I'm looking forward to spending more time with her and hearing how she dealt with JB as a young, wild child. And I think we have some fun questions for her. But first, JB, do you have any news?
You want to do the news? First on the list to discuss tonight is that we have a continuation of the public health emergency. But it does look like, so the public health emergency is what has been in act since COVID-19 happened. So it started in January of 2020. It was last renewed in April of 2022, but it's set to term. It's a 90-day revolving cycle. It's set to term in July. Looks like we're going to get a renewal on that. Now, why is this important? Well, for a couple of reasons. One, it gives the authority, the government, a lot of flexibility to make rules quickly for a response mechanism for a public health emergency. And so as we get further away from some of the real uptick of COVID-19, you do start to get a little bit concerned that maybe there's some bandwidth here now for some additional regulations and things to come down that we as private practitioners may have to figure out ways to manage. And as we extend the public health emergency, what we talk about very frequently when the FDA, CDC, HRSA, all the other organizations, OSHA, have to enact regulations, there are very specific parameters in which that comes to place. And usually there's open comment period, there's drafts, all the players that are involved in that, major organizations, practitioners, et cetera, have a seat at the table to sort of come up with some type of compromise and workable solution. As long as the emergency is in place, all of those things are to the sideline. So they're able to enact very quickly legislation and regulation to deal with whatever health emergency is currently in place. All I would suggest is that I feel like we've moved away from some of the urgency of responsiveness and should be moving towards an opportunity for practitioners and everybody else that has a seat at the table to have the open comment periods that we've been very accustomed to for a long time, to ensure that we understand the full impact when we bring new regulation and new legislation forward for the betterment of people, for the betterment of practitioners, et cetera. Jeffrey, what say you?
No, I get it. I love it. I agree with you on this topic that it's time to move forward.
Yeah. All right. Well, do you want to hear a really staggering statistic?
I do.
Listen to this headline. Are you ready? Global dental insurance market size and trends will reach $313 billion by 2027.
Gee, I wonder why the big corporates got into dentistry.
Here's the headline. North America is the dominating region in the dental insurance market, owing to increasing number of dental treatments in developed countries of the region. Whereas Asia Pacific region and global dental insurance market is expected to grow at the highest CAGR during the forecast period, growing GDP and healthcare expenditure and technology advancement is leading in the region. So, if that tells you anything about where we're headed and what is happening,
I'm a little nervous.
Yeah. So those are the two headlines. As I mentioned last week, it's kind of quiet on the
It's a slow time of year. Everybody's kind of out on hiatus. I get it.
Yeah. They're all vacay, you know?
I know.
And re-election, so they're not going to do anything that might damage their re-election potential. So all's kind of quiet right now. There's some stuff going on, CDT stuff. I'll give you guys some updates here before too long. But we have some new codes that are going to come forward that we definitely can have some extensive conversation about. And there's some other rumblings of some things, but nothing's gone public yet. They're not putting out that. I think that will wait till the fall. So anyway.
But it's funny that you mentioned that, because one of the things that we did today, we were really leery to do any fee increases during COVID.
Mm-hmm.
And we purposely tried to kind of hold the line. So we had realized that it had been a while since we'd done a fee increase. And I will tell you that, it is not fair for you to absorb everything that is going on in the economy, and you cannot realize the impact of just a small fee increase to get up into at least the norms of your area. Just a couple of dollars on a few different procedures, what that does for you is incredible. So you need to be aware of what your overhead is, and you need to be looking at your fee schedules, and so we actually did that today. We finally updated our fee schedule. Everything else in the world has gone up, so us going up a couple of dollars at this point is okay. It's a little different than in the middle of COVID, which I think was a little bit of a different story, but although it seemed people had more money then. But anyway, I would just tell you, be aware of your fee schedule, make sure you're in the ballpark, and don't underestimate what just bringing your fees to what you should be charging for procedures can do for you.
Well, with that being said, if you haven't renegotiated or looked at your insurance contracts as well, that is an opportunity. And I can tell you, having done a little bit of that in the last 6 months, they are open. Some are open, and hopefully those are the ones you want to continue. If you're going to have relationships with PPOs, it's the ones that want to continue to have an open dialogue about fees. And so some of them are out there and open and willing. A lot of bad press happens that I see about insurance companies lowering fees. And there are definitely a few bad apples that consistently do not care. But that is not the case for all of them. And so I would encourage you that if you have a relationship or have an opportunity, please make sure you're looking at those contracts. And if you need recommendations, there's a couple companies out there that do this really well as well for you, and would be happy to share those recommendations to anyone who's considering a renegotiation.
No doubt. Thank you for saying that, because I am not as astute on the dental insurance side.
Sure.
That's what I love about our show, is that we have 3 completely different practices.
That's right.
and we can all learn from each other and in how we run them. So JB, why don't you introduce our guest?
Well, what an honor that would be. So I'm going to introduce a friend of mine who used to be a teacher of mine when I was at UNC only a few years ago, I think, because I haven't really aged, and neither has she, as best I can tell. But Dr. Weisleder was a faculty member at UNC, and she was an internationally trained doctor coming back through the US. And so she pursued her additional training here in the US as part of the UNC system. And then her journey took her elsewhere. But for me, and I'll just be, very candid about my experience, she was one of the faculty members that genuinely cared about the success of her students, not just as a dentist, but as a human. And I spent several lunch periods just at her desk, sharing a sandwich and chatting about life before dental school, after dental school, and somewhere in between, and the nuances of all the stuff that one has to deal with. So for me, she's always been a very special mentor that I had during dental school that, had an impact, that we shared a few moments together beyond the clinical chair. And so it's a privilege and honor to have her here tonight. She specifically reached out to me because she really wants to talk about dental trauma, which I think is the thing that makes most dentists' little butt cheeks just pucker right back up. And so I'm really excited to engage. Becky, thank you so much for coming on tonight.
No,
hey, Becky, thank you for coming.
Thank you. And with that introduction, I think I have to leave now.
Okay. Thank you. Good night.
And good night. My job here is done.
Yeah. Thank you. Bye. Let me tell you, it has always been a privilege to be next to people like you, Jen, and now Jeff. Very nice to meet you. So it is. So I was so excited to be here, especially to talk a little bit about trauma that, as Jen said, it is always the, oh my God, what am I going to do time.
Yeah. Absolutely. So before we get into that, I want to talk a little bit about your journey, where you were born, coming into the U.S.
I would love to hear that too.
I think that's a really important part because I recently saw, there's no straight line to success. There's no straight line to where you're going to be. So let's talk about your journey.
So it has been an interesting journey. So I was born in Mexico City. My father was born in Poland, and he met my mom in Costa Rica.
That's the connection. I'm Polish too.
There's
the connection. Now I'm getting it.
You might be cousins.
We might be cousins.
You're my cousin. You're my cousin. Although I do want to tell you that my on my mom's side, her father was from the Ukraine. So maybe you're my cousin too from the other side. So anyways, so I did go to dental school in Mexico. But after dental school, I went to San Antonio to do a preceptorship in endodontics, which I thought in my mind, I am already a specialist. So when I met Martin Trope, who is the mentor of mentors, I can tell you he is my mentor and I love him to death. And I keep in contact with him. And every time I reach out to him, he's like, so what do you need now? What did you do wrong this time? So, but no, I can tell you, I thank him for my life. That's all I can tell you. So I met him. He offered me a job at UNC and I went. My parents already had moved to North Carolina and my brother was also there. So it was kind of like a family reunion. So I moved there. And when I got there, they told me, hey, just wanted to let you know that you are really not an endodontist. Okay, thank you. I didn't know that.
I've really felt like one for quite some time now.
Yeah, kind of like I did teach in Mexico and I presented myself as an endodontist. So I've been teaching since 1990. So you can imagine, today I was seeing a patient in the clinic. He was a child. And I told him, you have to speak louder because I'm old and I cannot hear you. And I said, how old do you think I am? I said, I am 105. And he goes, no, you're 40. You're 49. And I said, I'm taking you home.
You're mine now.
Yeah. Yeah. And he goes, no, my mom is there. I swear to God. That's what he said. So after that, then I had to do endo, right? Because how am I going to teach endo if I am not an endodontist? So Dr. Rivera, whom we spoke before, gave me the opportunity. And I did the specialty at the same time that I was teaching. So it was kind of like a little trip. But It was okay. And then after that, then I had to look for a job, you know, like grown-ups do. So although I was a grown-up already, but so I looked for a job and I went to Houston, and I was in Houston there, and I was basically the director in pedo endo clinic in trauma, dental trauma. And then, well, I had to grow up a little bit. So again, and I took a job in Kansas City. And then my chair decided that I look like chair material. Right. So I became board certified by the American Board of Endodontics, and I became a chair. And that's what I'm doing right now.
How do you like
interested? I'm
how
sorry.
do you like the leadership roles? I would assume you play as chair versus as more of a faculty direct professor. And maybe there's some crossover there, but.
Right. So here in Kansas City, we have a very tiny faculty, meaning that there is not too many of us. So I still teach 8 clinics a week.
Oh, wow. Okay.
So yeah. And then I also have time to do my administrative and to do my faculty development. As a matter of fact, I just finished my IADT, which is, you know, the boards. I didn't have the boards. Now I have the boards, and I have Reb. So now I think I'm done. So every time I say that, my friends go, nah, you're going to do another test. I'm like,
yeah.
We're never done.
Oh
So
my.
I'm curious, what got you interested in endo in the first place? Because it's one of those things that, you know, you're like, okay, I need to know how to do this, but very few say, oh my gosh, this is my calling. So I'm just curious what got you so deep into endodontics?
So I think it was basically because it is number one, is the only discipline that really saves teeth. Number two, is a very, very, very challenging specialty. And number three, I think it's the only one that combines surgery and dentistry at the same time. So I thought, I can do this. And also maybe, and I don't drink, maybe I was drunk one day and I decided it. No, I'm kidding. But mainly, I think those are the 3 reasons why I decided to do it.
Well,
So are you teaching now on trauma? Is that like an area of passion for you, or just an area you see as generally deficient for GPs and we need more in-depth understanding of how to manage trauma?
So that's a very, very good question. Very interesting. So the moment I get the patient that had trauma, I do not get them immediately after trauma. In Houston, I was getting them because I was part of the hospital. So I had privileges at the hospital. So I was part of the hospital. I would, anytime there was trauma, the oral surgeons will call me. At this point in my career, unfortunately, I don't have a private practice, right? So I am in the university. And when we get the trauma, it's late in the game, meaning they already were seen by a general practitioner that a lot of the times don't know how to react to certain things. And there are things that if you have them clear in your mind, you will save those teeth. And then by the time they get to me, maybe I will just say, hey, Dr. Bell did exactly what she needed to do. You don't need to see me anymore. Their trauma is so crazy because the moment you get trauma in your mouth, it's forever. It's done. So it doesn't mean that you are going to, well, I'll forget about it, and then all of a sudden it'll just, disappear. It always returns, and with a vengeance. I can tell you, yesterday I saw a consult on the floor. It was a patient that had trauma. You could see I am a very good historian in following radiographs. So I went to her radiographs, especially if they're patients of the school, then it's easier.
Mm-hmm.
So I saw her radiographs, and in 2013, there was nothing on the tooth. Then 2018, there is internal resorption that nobody diagnosed. And I know why. Because she had this toruses that, oh my God. And she's 87 years old now. Okay. So long story short, by the time she got to us, the tooth is, I would say that it's a questionable to unfavorable prognosis. So, but she wants to go ahead and do something.
Yeah.
If she would have been seen by someone that knew what was going on, we could just do the root canal and get rid of the internal resorption.
So
But
you
now
know
it's discrimination.
No, you know what's really interesting about that? So, one of the areas that I'm very focused on is TMJ and TMJ injuries, because almost all can be traced back also to traumatic injury. And so, one of the things we started doing on our medical dental histories is actually a trauma questionnaire,
Right.
because this is something that always comes back. Like TMJ injuries, typically you're not going to see symptoms for 7 or 8 years. And the same could be said about endodontic problems and resorption and things like that. So, how do we get more dentists to talk about trauma and get trauma histories from their patients, and then relate that to, hey, we need to be taking periapicals on the lower left, or we need to be taking a cone beam, every couple of years to look for changes. What are your thoughts on that?
So I can tell you that, first of all, patients do not interpret trauma as, I was running one day, I fell and I hit my
Right.
mouth and nothing happened. They interpret trauma as, I was in a car accident. They had to put 5 screws in my brain, in my skull, and in my arm. For them, that's trauma. So when I tell them, have you ever played sports? And I don't know if you remember, Jen, that we used to do all the mouth guards for the players at UNC. The Department of Endodontics was the one. So, if everybody would just remember that if you are a football player or a hockey player or any sports that are contact sports, you are going to have trauma. There is no other way. But let's say I had a friend, for instance, that I had to do a root canal on. She was a swimmer. And you would think, a swimmer? Yeah, when she turned in a competition, she hit her mouth. And she was like, I don't remember, why is my tooth black? I'm like, didn't you hit yourself somewhere? No. And then all of a sudden she told me the story. Well, one time, blah, blah, blah. And I'm like, that's where you hit your tooth. So people do not react to trauma like that. The one they react is if the tooth is avulsed. So, horrible case I had, this kid was playing baseball and the baseball practice was done. So another one decided that he was going to swing the baseball and he hit him in the mouth, exactly here. All the teeth, including canines, were avulsed. Like avulsed and canine, that's horrible. So they understand, but not the little one.
Yeah.
Does that make sense? And not even that. People that are boxers, ortho, that's trauma.
Yeah.
It's organized,
Totally.
but it's trauma.
Yeah.
Right.
And it's funny that people, even who play, because so many traumas, as you said, happen when kids are playing sports and things like that. It's amazing how many, especially like young ladies that play soccer, that say, oh, I didn't really play a contact sport. Well, yeah, soccer. I mean, how many times have you gone down on the turf and hit your chin, or gotten bumped with an elbow or something like that while you're playing? And you're right, it is dismissed very often.
Right, that's not trauma. Then the other thing also that is trauma is, and I see a lot, and that when teeth are immature and they start to get matured, they grow with the bone together. So they're basically going to guide the bone in a kid, right? So how many brothers and sisters have you seen that they have hit each other in the mouth playing or fighting or whatever? That for parents is not necessary trauma. It is.
Yeah.
Dental trauma keeps on going. So you have it, and then if your brother hits you again, then it goes up here. And then it goes, and so on and so forth. So the more trauma you get in that area, the worse prognosis you're going to have. Now, regarding general practitioners, these are the patients that come to your office first. And you have to be like the ER. and know exactly what to do, right? And not only that, you can make a practice and make a huge practice of you take a mouth guard with Dr. Jennifer Bell, and people will know, right? Or
Yeah.
in your church, in schools, everywhere. Here, this is my card. If you anytime have a trauma, blah, 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 call me, I'll be there. I'll make it happen.
No patient is more appreciative than when you take that phone call. And
Absolutely.
I had an adult dodgeball injury. I was at a pool party with some friends.
Wait, did you say dodgeball?
Yes.
You did.
Because if you can dodge a wrench, you can dodge a ball.
You can dodge a ball. But apparently not everyone can dodge a wrench or a ball. So she took, the ball to the face or somebody's elbow. Anyway, something hit the face and it was an alveolus fracture. Actually, all the teeth were still in bone. And so trying to put her back together, but I answered the call and I met her over there and we stabilized her and, currently, knock on wood, all is well, but it's being available and ready. And I think that's number one, that's the blessing and the curse for GPs for trauma is it's any time or day that you get that phone call that's like, hey, I need you to meet me at the office. My kid just slid down the slide and their tooth is somewhere in the playground somewhere and we got to find it. And how do you deal with that? And I know personally, you get anxious because you think you recognize the enormity of the situation. And it always seems the uniqueness of the situation because almost no trauma is identical in what you have to figure out. There are guiding principles that you sort of lean on, but it's always a different combination of problems, bone fracture versus tooth fracture versus avulse versus move versus complicated fracture versus simple. There's so many different nuances. And so is there like a general algorithm or a cheat sheet or a recipe card that GPs have?
Love a flow chart.
Yeah. If then this, then this, and kind of operate with best practices?
Well, that's a good question also. Yes. So, there's an app for everything, right?
Of course.
Let me show you the app. The app is called Dental SOS. And it's not that Tooth SOS. So
okay, wait. This is huge. You're giving away completely amazing free information here. I'm
Tooth
just
SOS,
saying.
and it's free. Tooth SOS, and it says, I have a tooth injury and how to prevent dental injuries. Too bad that you cannot see it very well, but I can. Here you are, probably.
Oh yeah. Mm-hmm.
You can see yourself in the mirror. But it's from the International American Dental Trauma Association.
So we should put that up tomorrow. And I'm sorry to interrupt, but honestly, this is the kind of stuff that people tune in for. It's like these kind of tips are so valuable, and to be able to hear that and, okay, it's not going to cost me anything. I don't have to fly to Europe to learn this. Amazing. Thank you.
Right. So that's one thing. The other thing you can do is the American Association of Endodontics has guidelines. They're together with the Dental Trauma International Association, same thing. And you can see exactly, if you have a luxation of a tooth with an open apex, what do you do? Boom. And the guidelines just changed in 2020. So there's new guidelines, and it tells you when do you have to see the patient, when do you have to take the radiograph, if you have to take the radiograph, if you have to do testing, how long the splint has to be in, if there is a splint that has to be placed, and so on and so forth. Those are things that they're all online, but the Tooth SOS, I love it.
That's great, because so many times when this happens to a general dentist, it's not during regular hours, right? It's like it's the after hours call, someone in the community, you want to do the right thing. You want to go in, you want to help them, but you don't have all your normal resources available to you. at that point. So stuff like that is just amazing. Thank you for sharing that.
Oh,
Well,
no.
what has to happen now versus 12 hours?
Right. Like
Or-
what I just want to do the right thing right now.
Right.
Or just the phone call when the parent calls you, hey, I have the tooth in my hand. What do I do? Just put it in. Put it in. Just let them know. And it has happened to me. That's why I'm telling you that you have to put the root inside, not the crown.
No.
Oh, yeah. So the crown was in. It doesn't matter.
I get that because a lot of my patients use the wrong side of the toothbrush.
Well, I agree. I agree.
I'm almost positive they're using the wrong side of the toothbrush.
And they would put the tooth back
the
up.
The side with the little prickly things will clean your teeth so much better.
Very effective. All right, I have a question because it's on my mind. Talk to me about stem cell regeneration with, there are some endodontists out there that are dabbling or trying to understand better using regenerative techniques, especially for open apex cases. So let's talk about, is that a practical approach? If so, how effective? What's the data showing? And then, if endodontists aren't using that particular technique and it is effective, where do they learn more about that?
Okay. So good questions also. Did you do your homework?
No. I hate endo. So these are all the things I send to my patient or to my endodontist.
Gaby always does her homework.
Always.
I know.
I don't like to do it, but I want to understand it. How's that?
I know. Yeah. So, and it's so funny because it's like you're touching all the things that I love and I am passionate about. Like I cannot even, you see it coming from my blood. So regeneration is something that I have been doing for a long time. And everything is case-based, meaning you have to choose your battles. So what we do is it's called and it's wrongly called revascularization because we really do not have revascularization. What we have is we have a formation of connective tissue that sometimes is osteoid and sometimes is type of a cementum type of, okay? The important thing is you have to keep the teeth in the mouth the most time before you can place an implant, right?
Right.
The more time I can get for that tooth that grows together with the child, then we're good. Although I can tell you that I have cases with recalls of almost 10 years and they're still in mouth and they matured and they don't need a root canal. They don't need anything. It worked. And some of them don't. What makes it work and what makes it not work? As I said, case selection. And also, what is your own technique? There are several techniques. I use the one that Dr. Trobes showed me through the literature. And it's the one that also San Antonio has been advocating. And it works. Now, what happens if it doesn't work? Well, then you can do apexification, which was what we did before. But now instead of, putting the calcium hydroxide and waiting for this to happen, you just put either MTA or BC sealer. There's very many bioceramics that you can use. So I think the game changer has been bioceramics. So number one, bacteria. You don't have bacteria, you don't have disease. That's in dentistry, period. And if you have a good seal, then you win.
Yeah. When you talk about your technique, is that an apex technique? Are you going apically to treat or because you're suggesting that they may not ultimately need a root canal. So when you're doing these regenerative techniques, what's your approach? What's your technique to doing that?
So the protocol that I use and the residents use when I'm there in the clinic. So we irrigate with 20 mLs of 1% sodium hypochlorite. And then we disinfect with calcium hydroxide. We don't take one file inside of the root canal that day. Obviously with anesthesia, rubber dam, blah, blah, blah. And then we close. And then several protocols say you have to wait 3 weeks. Others say 1 week. Depends on our clinic availability. That's what I can tell you.
Yeah.
Then they come back and then we irrigate again to take all the calcium hydroxide out that did the disinfection. And then we use EDTA 1 or 17% EDTA 1 or 2 drops, just because that's what is going to help you with the growth factors as well.
Mm-hmm.
And we do a poking in 1 millimeter from your working. So if you do, so basically you're poking the apex because it's open. Now, obviously, if it's 1 millimeter open, it's easier than if it's this big.
Yeah.
And then after that, you have to wait. All is this under microscope. So of course, it's kind of like technique sensitive. And then you wait for your coagulum to grow and to mature around 15 minutes, so on. Also, I want to say the anesthesia that you have to use is with no vasoconstrictor, because if not, you won't get the bleeding, right? So that's the second visit. So then you wait for that coagulum to be mature, and then you place what I place is Colla-Tape, which is a collagen. It's a collagen. They sell it as collagen.
Yeah.
And then you put it as on top of your coagulum. So when you put the bioceramic, it won't just fall down. And then Vitribond and a wonderful seal with a good composite. That's it.
I think more endodontists, I know not all of them do those types of techniques, and it's really helpful. My endodontist does, and that's definitely always part of our conversation when we have young trauma. Can we do some type of regeneration? Can we save this tooth in a more non-traditional format and enable it so we can buy time? We're just buying time.
Right.
Yeah.
You're buying time. I can tell you, I have bought time with fractures that have been in green stick. So what we did with that kit, and I have a recall of 5 years. I was going to present this poster in the trauma meeting in Portugal, but they canceled it. How could they cancel my Portugal trip? But they did. And and I have a recall of that patient. What we did is when he came, if you don't do a CBCT, you will never be able to see a crack in the palate or a fracture, right?
Mm-hmm.
When we did the CBCT, what we did is we opened a flap, we took the piece out, we did the root canal, and then we put a post, and then the same tooth, we used it as the tooth. And then we rebuilt it, so the kid never knew what was wrong, in a sense of it didn't even look different. And I have a follow-up of that for 5 years. Same
really
tooth.
Cool.
Same tooth. And that tooth is going to be there until either he finishes growing and he needs an implant, or maybe never.
He hits it again until he hits it again.
Until someone hits him again.
Right.
Exactly. Yeah. What about what are your thoughts, or and a lot of people don't have any at this point, any thoughts on ozone therapy for pulpal exposures and treating the bacterial component of pulpitis?
So I am not familiar with the ozone, but I can tell you that right now the studies from Ricucci, and Ricucci is an Italian general dentist that does more endo than anybody I know, I guess. But the important thing about him is he does histologic studies with everything that he touches. So he has so many things to teach us. And what he has taught us is, why do we always think that if we have a pulp exposure, then the pulp is going to die? So it's like we say that is.
I love that.
Right? Like,
I love that.
Why couldn't imagine? So what we're saying is every single tissue in our body can heal except the pulp.
Right.
It's connective tissue. The only difference is the bacterial load.
Right.
So if you can eliminate the bacterial load, so for this, we do direct pulp cap using bioceramics. Bioceramics has been the one that has changed the game. Changed the game 100%. Because I remember when I was in dental school, in 1495, when you had a pulp exposure, it was automatically you go for root canal. No matter what. Open, apex goes, no matter what, you go for root canal.
Right.
Here, no. Here we are even thinking about adding it to the curriculum or the DDS to learn how to do vital pulp therapy, which is doing this direct pulp caps on patients that maybe won't need the root canal.
Right.
Of course, it is a protocol. You need to know, you need to do with 2 burrs, 1 burr, which would be your dirty burr that will take all the caries out. And before you have the pulp exposure, then it's your clean burr and the microscope. And then you have to see the bleeding and so on and so forth. And then you have to stop the bleeding, but it works. And I think this is where the future is going to go in a lot. Of course, I'm not saying that then root canals are going to disappear. Don't worry. Root canals will always be here. As long as we have bacteria, we'll be fine.
Yeah. Job security.
Oh,
and as long as there's bacteria and bad dentists.
There you go.
Yeah. I didn't say that.
And bad materials that I am not going to say which, because I don't want to get sued.
Yeah.
There you go.
I might ask you if you have any inclination to post, I think our audience in particular is mostly GPs, but I would love to dive deeper into the direct pulp cap and indirect pulp cap, the current, best techniques. And because I think you're right. And not only to prevent the root canal, but there are just some populations, if you can do that well, they can't afford the root canal. So it's, you do what you can do, or we take the tooth out. So if you have a good, handling of that information, you've at least got a fighting chance of maybe saving the tooth. And I think we underestimate the value that we can have for patients.
And why would we not try? Why would we want to take more tooth structure away to do the full endo access? And
there's sort of after. But now I don't know if you are familiar with the ninja access, which is they do this little accesses. I come from the old school where the access is you take all the caries out and that's the way it is. Here they still take the caries out, but instead of going into the pulp chamber and having a good access and straight line access, they do these ninja accesses because of the files that we have now, and they work. I'm not saying they work on my technique in my hands, because doing root canals with different techniques is just like brushing your teeth, but with the right side, not with
the right side of the toothbrush, right?
Right. It's everybody has their own technique.
Yeah, but you're right. The files have changed that.
Right.
Yeah.
Of course. Like some people use this file, some people use these other files. It's okay, as long as there are very many ways to skin a cat. But I do agree with you on how many people cannot afford a root canal. So it's either you take the tooth out and then all those problems starts, because if they cannot afford a root canal, they cannot afford an implant, right? And they maybe cannot afford a bridge. Right. So then what are you going to do? So I think that is something that is going to work out pretty well.
All right. Inquiring minds want to know, where is Resilon? Is it still on the market? Is it still a thing?
So Resilon is not in the market anymore.
Okay.
I don't know a lot about Resilon since I left North Carolina.
Yeah.
Although I know things that it didn't work in some ways, I can tell you my board cases were all presented with Resilon. And for all my board cases, I had more than 5 years recall, and they were still in the mouth and they were looking beautiful. Resilon is not in the market anymore because nobody's using it.
Yeah.
Jamie, tell everyone what Resilon is, just so.
Why shouldn't Becky? So resin alternative to gutter purchase.
Resilon was basically an obturating technique that was saying that it would create a monoblock between the dentin and the gutta percha. Okay, and that was the intent, to intube the bacteria, which that's what we try anyways.
Right.
And that it would be successful in obturation. But at the end, it wasn't what it was expected, and it moved on and nobody died from it, and that's it.
No, it's just interesting Because that's
It
all
wasn't
I learned
Sargenti
on.
paste.
No, it's not Sargenti.
Oh no, Sargenti paste. No.
No, it was FDA approved.
There you go.
All right. Well, we are at 9:29. Becky, I could talk to you all
It goes
night.
so fast.
Yeah, it was. And there's so much I want to learn from you. I mean, this is something that I think every GP needs to have some kind of a grasp on is, you know, listen, even if you don't want to do a lot of root canals, even, you know, you don't want to be an endodontist, you've got to understand how to treat trauma. You've got to know what to do with the indirect pulp caps and the options for direct pulp capping and when you should be referring and, you know, when you should be keeping it. So I'd love to have you back and talk some more because, you know, who thought endo was this interesting?
Imagine that. And I can even share some cases with you.
Would love that.
Oh, that'd be awesome.
So yeah, anytime, just shoot me an email, let me know when, and you know, we can do it.
Sounds good. Well, thank you so much for joining us. And we will bring you back, and we appreciate you taking your time to hang out with us tonight.
Oh, my pleasure. And also congratulations on your 100th show.
You said it before we did. This is our 100th show.
And it's a pleasure that I was the person invited for the 100th.
And I'm honored that you were the person that did it.
My youngest today, I said, hey guys, it's my 100th show. And she goes, how many more do you have to do?
And then you answer as many as I want to.
I was going to say, it doesn't quite work that way until they kick me off.
As long as it's fun, we'll keep doing it.
That's right.
I agree. Congrats and thank you.
Thanks so much.
Thank you so much for coming on.
My pleasure.
It's great to see you again.
It's great to see you too and to meet you, Jeff.
Have a great night. Thank you. You too. Bye-bye.
Bye.
JB, awesome. Loved her.
My mentors are great. I don't know.
Well, I mean, if you call someone a mentor, I mean, they're gonna be great, right? If they're a mentor, they're gonna be great.
Do they see me as a project? Is that the problem? Like all the really good ones are like,
yeah, well, you know, she talks a lot and maybe she thinks too much.
Maybe something there. We're gonna dust it off a little bit and just see what we can find. Yeah,
we'll get to the bottom of all that. But no, awesome. Thank you for inviting her and you know, this was really a JB show. You love what you do.
Next, moving on.
Moving on. Okay. We love JB. We miss Chad tonight. Always miss Chad when he's not here. But thank you for watching our 100th show. Hope we're doing at least 100 more because this is fun. And it's just great bringing lots of good information.
Can I do a quick plug for us? So we're really getting active, as I mentioned before, on our podcast, and we're converting a lot of our regular shows to podcasts. So if you want to catch an episode that you missed, but you want to consolidate it down to just the one, you want to consume it in an audio version because you want to catch it while you're working out or walking the dog or doing whatever, the podcast format will be the place to go. But our new intro music is a definite must hear. And so, you know, I got to say, you got to go hear the next podcast just for the intro music because it is that good. And Jeff does a phenomenal audio intro. It is good.
It sounds kind of professional. Kind of.
I think the guy did a great job.
As professional as we can be.
We have professionals working for us to make us look better than
No doubt. No doubt. Well, JB, thank you for everything you do. Love you. Chad, love you. Miss you, brother. And everyone, have a good night.
Good night.
Yeah. Good night.